not only to launch this under Jacob's and others' leadership, but to have the amazing Dr. LaRon Nelson be our first speaker. So the School of Nursing Global Health is really at the heart of so much of what we do, and it's at the heart of our mission. And this lecture series will really help us deepen our impact in this area and see how all of our programs of research could really benefit by having a global. So it is now my honor to welcome Dr. Lolita Kalagatla, Executive Director of the Lillian Carter Center, to officially kick us off. Thanks.
Thanks so much, Jim, and thanks everyone. I love seeing the turnout here. This is amazing, and no surprise, given Dr. Nelson speaking here today. Thanks, Kim, for being here as well. And this is truly an exciting step forward for us here at the Lillian Carter Center. This lecture series will spotlight cutting-edge global health research, strengthen our international collaborations, and inspire innovative solutions to some of the world's pressing health challenges. For over 20 years, the Lillian Carter Center has been at the forefront of global health concerns, as many of you in this room know, and community-based work. And this series is a perfect extension of our mission, carrying forward the legacy of our namesake, Lillian Carter, who is not only the mother of a U.S. president, our own beloved president, the late President Carter, but also a dedicated nurse and a Peace Corps volunteer. In fact, she actually was a Peace Corps volunteer in my native India, in my favorite city of Mumbai, as a matter of fact. So that holds a special place in my heart. We're thrilled to have all of you here with us for this event, and look forward to the impact it will have in the years to come. And now I'd like to turn it over to my wonderful colleague, Dr. Jacob Kariuki, to speak about his interview.
Thank you so much to all of you for being here. And I know you're saying, like, get out of here, we need to hear the speaker. Before you do that, I'd like to make a few comments about about this lecture. This is supposed to provide a platform for inclusion of thought leaders in our community to share their personal experiences and insights about building sustainable global health research projects. And also, in the process, we hope it will inspire a lot of you to get more involved and more interested in global health research. This year, we are kicking the series with 3 powerful installments. So the lecture today is going to focus more on emerging threats and priorities in global nursing research. And then in the summer, we will be focusing more on interdisciplinary approaches to solving global health challenges. I think we need a lot of that. And then in the fall, there will be a lot of focus on social determinants of health and addressing global inequity from a global perspective. And the whole idea of doing all of this is actually, like I said before, to probably foster new collaborations among ourselves and our speakers, and also to invigorate new partnerships that are going to contribute to our overall mission of making a difference in the global health space. And I know we want to get to the speaker today, so let me turn my attention to the one who has the privilege of introducing the speaker, and that is our 2025 president of our MN cohort, so Gloria Tommy Johnson.
Good afternoon, everyone. My name is Glory Tommy John, and I'm proud, really proud, to be part of the Emory 2025 MN program at the School of Nursing here. And it is my great honor to introduce today's distinguished keynote speaker, Dr. LaRon E. Nelson. It's such a great pleasure. Dr. Nelson is the Independence Foundation Professor at the Yale School of Nursing and serves as the Director of the Justice, Community, Capacity, and Equity core at the Core for Interdisciplinary Research on AIDS at the Yale School of Public Health. His groundbreaking work focuses on developing and testing multi-level intervention strategies to combat the spread of HIV in the United States, Canada, and Ghana. He also researches the rapid treatment for post-traumatic stress symptoms in communities affected by trauma, including those impacted by extreme weather events in Kenya and China. Beyond that, Dr. Nelson is deeply involved in investigating economic and financial factors that influence the adoption and sustainability of health innovations. His research has been supported by prestigious organizations, including the National Institutes of Health, the Canadian Institute of Health Research, and the Lee Foundation. Dr. Nelson is not only a respected researcher, but also a dedicated leader in global health, serving as a fellow of both the New York Academy of Medicine and the American Academy of Nursing. Please join me in giving a warm welcome to Dr. LaRon Nelson.
Thank you. I think I'm going to need some help with things. Okay, awesome. Thank you.
Thank you.
Okay, good afternoon. It's a pleasure to be back here at Emory. I was here about a year ago, actually, for the Ada Ford lecture, and it's an honor for me to be back to talk to you again. I thought about, somebody asked me for my topic, I don't know, months ago. I gave my topic, and I wasn't sure what I was going to actually say until just a few days ago. So I think I'll start talking about something I heard on the radio. Yeah. I was in Oakland, California, listening to Bishop Yvette London, and she was giving a sermon. And this is the title of the sermon, Monuments and Movements, something like that. So in her story, she was talking about growing up in San Francisco and growing up in a place where the earth moves. And, you know, learning what you have to do when that happens and not knowing when it's going to happen, not knowing how bad it will be. Sometimes it's not bad at all. Sometimes it is catastrophic. Things can go from being magnificent to being rubble in seconds. And she talked about these beautiful San Francisco landmarks and buildings and monuments, and to walk around after an earthquake and see what happened to them. And she thought about why this could be happening. Meaning, why are they building buildings like this when we know that this will happen? You know the earth is going to move. And she said she thinks it's because these buildings are these static, beautiful, wonderful things that are piled deep into the ground that they assume is going to stay put but for a long time. And sometimes it stays put for a long time, and sometimes the earth moves from under you. But they've had to retrofit these buildings. They had to do something different, figure out a way to allow the buildings to absorb the movement of the earth. So they put, I don't know, like hydraulic stilts underneath them so they bounce. I was in Midtown the other day. I see they have hydraulic braces on the buildings. So if the building moves, if the earth moves, the building can move with it. But she talked about the need to think about how we build our monuments and what they are designed to withstand. And that we have to think about what we build, like San Francisco people thought about the buildings that they build, knowing that sometimes very, very catastrophic things happen. This is Bishop London. her point in this sermon was that seismic shifts are a fact of life. They will happen. The issue is, are we sufficiently prepared for them when they happen? Do we weaken just a little bit? Do we withstand completely? Or do we fail and crumble in seconds? Right? So I was thinking about that as I was coming here, and I thought about what this means for how we build things like educational programs and research programs. And this is just an example of something that is built, that is stuck into the ground, that they assume is static, not alive, not dynamic. And this is one that is, maybe it's not as sturdy as you might expect it to be, but you can see when there's some friction in the earth that this will find some way to absorb that and move. So I thought, man, we got some really nice monuments, right? We have Emory, this building we're standing in right now, Yale School of Nursing, just as two examples of these monuments. These things that sort of were built, and I'm not just talking about physical infrastructure, these institutions that were built with certain assumptions, that things will be this way forever. Right? You know where I'm going with this. So, but we also know that the earth has moved, right? The ground is shifting. At age, that funding is under threat. You heard about potential caps, freezes on certain types of research programs, elimination of certain programs, of certain titles. A friend of mine who is the director of Octavation Research was like fired on a Wednesday and hired back on a Friday. Like it's crazy. USAID, very large fund of global health activities, both research, service, clinical programs, that got stopped, right? You know what happened? Things crumbled in seconds. Programs went away in like this. Imagine that. Imagine having built this huge, beautiful, wonderful programs in Kenya, in Ghana, in Tanzania, in Indonesia, and then one day the earth moved. The question is, what do we do about it? I don't exactly know. Michael probably knows what to do about it, but there's some things to think about. First, I say that this is a deliberate attack. And when I say attack, I mean that it's not accidental. This is a deliberate dismantling of the infrastructure of these programs, both global health and research. I don't know why it's happening. I mean, there might be some strategy for why it's happening. What I could come up with is that these people, President Donald Trump, the other president, Elon Musk, they come from the business world. And and it seems to me that this is a way to sort of clear the deck for something else, for something new to come along. I don't know what that is. I don't know why that is. But that's the only rationale I could give it to myself. And what it could be is making room for insurgents. I'm using this language because they talk about this in sort of the business world. I'm trying to think about this from the standpoint of people who spent their careers in business. To make way for new kids on the block, to do something different, and as a way to attack incumbents, right? In the research world, Emory, Yale, Harvard, MIT, Georgia Tech, these are incumbents. We've been riding high for a long time, right? And without any, what's the word?
Disruption.
Maybe disruption, without any real threats to our positions, right? Firmly entrenched, right? But if you think about the history of incumbents, right? There's always a new kid coming up, right? Who here remembers Southern Belle? A few
I used to
people.
work for him.
Could you imagine a day where there was not a Southern Belle when you went there? It'd be hard to imagine.
Right.
So back in the day, we had these inventions, these things that everybody relied on. There's no way we could ever get by without this. It was inconceivable that something else could come along. And yet, something else came along. Right? Southern Belle, that's what I grew up on, Southern Belle. We had phone books and all that kind of stuff. How many people know what a phone book is? So at some point, the incumbent becomes the insurgent. So many people heard of T-Mobile, even though many people have never heard of, maybe everybody's heard of T-Mobile, and not everybody's heard of Southern Bell. That used to be king of telecommunications in this city, in Atlanta. It was inconceivable that you could live in Atlanta and not know what that company is. But many people would have no idea. It's gone. How many people heard of Hollywood Video? Blockbuster Video. Could you imagine the time when you couldn't go on a Friday night, go home, or all the way home and stop at a Blockbuster Video? It was everywhere. You couldn't walk down the street without seeing one. It's gone, right? There was a resurgence. Somebody else came along with something different. So I'm saying that to say these disruptions are not new in history. They might be new in academia. Right? I'm not sure we've had this type of earthquake, maybe ever, or certainly in a very, very long time. But I think this is what's happening. The earth is moving. The ground that we sort of built our institutions on is shifting. And we have to figure out who's going to take advantage of that. Who are going to be the insurgents to take advantage of this chaos? So I don't know what's going to be next. We don't know what's going to be next. I should read this. But we know that the earth is not going to stop moving. Something's going to have to replace it. Something always does. So we have to think about that. We have to think about, in the global health research, are we going to be immovable monuments? Let me even say that differently. You can't be immovable monuments. You will either figure out a way to shift, or you will fail. You will be obsolete. You will cease to exist. So in the private industry, they talk about these things called competitive cycles, kind of go around. A cycle of being in a position, of being in a game of movement, and then a game of imitation. So I should look at my timer. Okay, good. So I'll talk about each of these things. So so first let me back up. I'm an ex-military person, I'm a veteran. So I think in sort of wartime, it helps me understand my topic. So forgive me if it feels very sort of war-oriented. And I'm also in global health. I spent a lot of time in China, and I like the way the Chinese think about strategy. And so some of this quotes from there. But the war position is the status quo. That is where we are now. It's the normal status of how things work in global nursing research. We know what our competition is. We know what it means to win. We know how to win. I came here last year and I met with students who were talking about writing grants, research grants, right? Students talking about writing NIH research grants. Why? Because Emory knows the sauce. They know the recipe. They know how to win. They know the rules of the game. That knowledge is accepted and taken for granted. Everybody knows what you got to do to get to a PC program, to get to your advancement and promotion and tenure. And we know what the critical success factors are. What you got to publish, how much you got to publish, where you should be publishing, where you should be presenting. All that is status quo. Everything's cool. Everybody's floating along. So in the status quo, there can be what we call this game of position. So that is when they're trying to capture your share of an available market. So right now, even though there's quotes that saying this freeze should be paused, I think you should accept that this money is frozen. I have grants right now that have stopped. The money has not been released, right? I think we should accept that this administration is going to push as much as they can. So let's get into that mode right now. The money is slowing down. Some of it will stop. So that's a smaller pool. A smaller pool that's going to intensify the competition for that money. Right? Some places, at least research institutions that are driven by research won't even be able to survive that. To go from 70%, 67, I think Yale is 67% indirects. To go from that to 15%, I don't know. You got staff, you got to pay. Some people don't own their buildings. They got to pay that building. They can't pay that. They can't operate that with that little bit of indirects, right? So the leaders have to defend their share, right? They need that NIH money. So they either got to keep it at 67% or 70% or whatever it is, and keep other people away from it. That's what's happening now. The fight right now is to go to court and to defend the share. The followers, so the folks who can get by with 15% will attack, right? They will say, Yale can't keep that up. They got all those expensive professors and those expensive fancy buildings, 70% to 15%. There's going to be a lot of people out there, a lot of companies who want some research done, and they won't be able to do it. They're too big. They can't be nimble, right? So trust me, there's a lot of companies out there waiting to get in, right? That's normal. I think we haven't had to grapple with that, but that is how it normally goes in these competitive cycles. The ones who are sort of boutique artisans will figure out a little small piece of the pie that they'll take. But it is a zero-sum game. Right now, everybody has a chance to get something because it's a lot. It was a lot of money out there to go around, especially to the incumbents, the ones who know how to get it. That pie is smaller. So now there's going to be a really serious war to figure out how we survive this thing, especially in places where they've not figured out how to do something differently. Always in this model. The second part of this cycle is called the game of movement. And this is really interesting. The game of movement is saying, it is accepting that there's a war going on over here with these limited resources. We got to figure out how we win this particular war. But not everybody's going to be fighting that war. They're going to be someplace else, doing something else, finding something new, a new market to fill, a new way to find or create value, but a way that allow them to win at their research without being in direct confrontation with these other competitors. It's based on this Art of War. It's a book written by a Chinese general. But the goal, I guess the philosophy of this is how to win without fighting, how to win without direct confrontation. China's actually very good at this. I mean, if you believe what you see on the news or whatever comes on across the screen, you would think that China is still back in like 5 BC. Right? They are not in many ways directly trying to compete with the US. They are already figuring out other things. They're way over here, right? We're talking about China, we're defending our things. They are not in this, they are over here, right? And by the time we figure it out, they will have won. And I'm not being like a China champion. I'm just telling you the truth. They're playing this. They've realized we can't directly compete with the Americans on America's terms. So we got to find a new way to do this, right? And at some point, the world will come over there. They did it with TikTok. They said, we don't need a Facebook. Why try to go up against Facebook? It's a waste of time. Let's create a new thing and make the world come over here. No one's going to mess with us because we're in this new lane. And by the time they figure it out, we've already won. So I think right now in global health research, we have to be playing the game of movement. We got to be thinking about what's next, about how do we win, even though we cannot completely rely on the federal government as our primary research sponsor, whether that's NIH or whether that's HRSA or whether that is SAMHSA or whatever you might think about. So I propose that there should be a value-based research where the reward is for impact, not just discovery. I'm gonna have to spend some time on this. So one Y'all might disagree with this, and you can tell me if you do. The way I see it, the research world is sort of like it's operated like suppliers, like in the supply mode. Like we supply evidence, and for somebody else to use and build something and design something. Much like maybe, I don't know, I'm not a construction, but we're in a construction room. You should know this. Like maybe Mopar. I heard of Mopar. They make parts for cars, right? They don't make cars, but they make parts for cars. So they make a bunch of parts, they stockpile them, and hope that somebody's going to come along and grab some things, take what we built, and make something. I think that's what we've done. We've spent a lot of time designing studies and creating evidence to supply some market. For somebody to come take it off the shelf with some pieces and build something, design a solution. I think we have to move away from that. It has to be part of what we do. Meaning, it won't be enough to just supply evidence as raw materials for somebody else to take and do something. When I was in my PhD program, Dan Morrison Beatty was my chair. Bernadette Melnick was the PhD program director. She would be, I want to say going crazy, but maybe that's the right way to say it. She'd be going crazy about how long it takes for evidence to get into practice. That was her thing. It takes an average of 15 years for evidence. I mean, she was saying this a long time ago, and it really was frustrating her. Because I think she could even see back then is that we're creating this stockpile of raw materials, right, and waiting for somebody to figure out what to do with it. I think that's where we are. In the context where the money is smaller, where the competition is stiffer, I think we need a different value proposition, which is we have to figure out some way to convert this evidence into something that is closer to a solution. I might have to figure out a better way to say that, but let me say it again. We had to figure out a way to convert this evidence, these papers, these presentations, as sort of raw materials and leaving them there to trying to come up with something that we can offer to the world aside from this Home Depot version of a bunch of papers, right? I think it could be facilitating the implementation of evidence into clinical practice, and it has to be part of the research process. It can't be sequential. It can't be something we figure out after we've generated this evidence. One, because depending on how the funding mechanisms shape up, I don't think people will accept it. I want to say suffer it, but that's probably not the right way to say it. I don't think people will accept that you'll just develop this now, and then some years later you'll figure out how to make it make a difference in my life. I think those days are rapidly going away. We have to be figuring that stuff out now. There's companies, there's a company called ViiV Healthcare. They make HIV medications. And we talked to them a long time ago about this new medication they were making, an injectable medication. And we said, you got to figure out how you're going to actually make this thing work in real life. They can figure out, can it stop the production of HIV? They figured that out. They didn't figure out how to actually make a difference in anybody's life in the real world. Right? I think, and in Munich at the conference, there was this big, maybe it was called a protest, of folks saying, don't do that again. All you companies, don't make new medicines that work in your studies, but do nothing for us in the real world. You got to figure this out now. And I think it could happen. So let me back up. So the drug companies are saying, how can you do that? How can we be figuring out implementation when we haven't figured out efficacy? And they say, I don't know how, but you better figure it out, because that's what we're investing in. The public's not going to support this unless you can almost guarantee them that you know how to make it make a difference in their life. And another point is that somebody will figure it out. If it's not them, right, somebody will figure it out, and a surgeon will come along. So I'll talk a little bit about HIV research, since that's what my background is in. In global HIV impact research, impact meaning research that actually makes a difference in people's lives, there's a lot of behaviors that matter. Traditionally, we talked about human behavior. Do people wear condoms? How many partners do they have? But there are other important behaviors: markets, health systems, how social and cultural systems behave, and how political systems behave. If we're going to have HIV impact research, we have to take into account all the ways that these various sectors behave. There's some models that try to tell us how to do that. It can be very complicated, but these are things you have to take into account. What are the social political forces? What are the economic forces? What are all things happening within the context of a local environment healthcare system? And all that has an impact on what happens, at least in nursing and the clinical encounter, which is the place where most of us expect our evidence to take place, to be implemented. So I'll give an example from a study. One is a US example, one is an example in Ghana. This is the HBTN study, HBTN 096, funded by the National Institute of Allergy and Infectious Diseases and National Institute of Mental Health. We designed this study because the rates of PrEP use among Black communities was low compared to their need. This is a chart from Patrick Sullivan, who is right across the plaza, who studies what he calls the PrEP to need ratio, which is what's the proportion of people who actually need PrEP and actually taking it. So what this is showing, this is showing that PrEP used by race has increased over time in general. But if you look at this one, these are folks who identify as white, that their PrEP need ratio is much higher. I mean, they have much more access to PrEP than they actually need. They have much fewer HIV infections, but yet extraordinary access to PrEP compared to other racial groups. Over time, this is a 10-year, 11-year period. Multiple innovations have come to the marketplace. Truvada, which is an antiretroviral to use for preventing HIV. 2012, a new drug, Descovy, just a better form of this, came out in 2016. Then in 2021, what I just talked about, this long-acting injectable drug has come out. But what has happened during that time period is that the racial gap in HIV infections has widened, it is not narrowed. Because some groups aren't getting access to these things. We haven't figured out why. We know the drugs don't work differently depending on your skin color. But folks aren't getting this. So while the HIV rate has come down dramatically in white MSM, white men, not sex men, as you would expect it would, for a long time, even with the introduction of these innovations, it's almost been unchanged. So we designed a study to address that. This is an integrated strategy with 4 components, which I won't get to in depth. This is how we expected it would work: increasing social support, reducing stigma in healthcare facilities, addressing structural barriers, and improving individual agency, right? And if we did that, we can increase people's enrollment in care, we can increase their retention in care if they have HIV, and if they don't, we can increase rates of PrEP use. That was our theory of how this would work. We designed it to be a interrupted time series, meaning we would assume there was some background trend. So at this time, there's all this work of ending the HIV epidemic that's funded by the federal government. So everybody's in these schemes are doing something. So we assume that there'll be some background improvements in these outcomes. That is not the result of our study. We would look back from 2 years from the time we started our intervention and see whether or not our intervention changed the curve of that, slope of that curve. And we were doing this in the South. So because the South is the place where the most HIV infections are happening, including in Atlanta. We didn't pick Atlanta for this study, but we're doing it in 4 cities: Dallas, Montgomery, Fort Lauderdale, Broward County, and then Miami-Dade County.
Hey.
So this is our, pretty proud of this figure, because we built it to mimic like a pill. These pills that are these sort of multi-combination therapies in one pill. And they do this because the various drugs in the pill attack various points or disrupt various points in the HIV life cycle. So if you can use one, but the effect of that will be limited. If you use 2, one that tackles one part, one tackles another part, the likelihood of inhibiting the viral replication is higher, right? So we thought the same logic. Yeah, there's a lot of things going on in communities, right? And if we just attack one issue, let's say stigma in healthcare facilities, we missed that there's a lot of social support that's needed outside the facilities. There are structural issues that need to be taken care of that are not about what happens in the clinical encounter. So we built this thing with these multiple components to address different drivers of HIV inequities in Black communities, with the goal of helping increase people's access to testing, PrEP, and to treatment. Could you think of an issue that's missing from this? That's a very practical question. So you just saw this for 30 seconds, but if you look at this, you think, okay, this study is going to help address PrEP use in Black communities with men of sex with men using this model. Some of you are nurses, maybe many or most of you are. You were looking at this, what might you think? In my clinic, would this make a difference? If yes, why? Or more importantly, if no, why not? Think. Say it aloud. Cost. Did you say cost? Do you work in an HIV clinic? Okay. Cost, right, cost. Somebody over here said access too. I heard it was access. So PrEP access is limited by primarily cost. Who's paying for it? The drug companies have an interest in making sure that it is priced right so they can recoup their investment. Insurance companies are thinking about what it's going to cost them to pay for these things. We did not factor that into our original plan. So we were faced with, what if we do this? What if we generate this evidence? We supply the world this evidence, but nobody can pay for this thing. What difference would it have made? We would have learned something. We would have discovered an answer to our question, but we will not have had an impact on that chart that I showed you. So this will be planned for. Increase PrEP awareness, address provider reluctance to prescribe PrEP, think through stigma discrimination for Black and LGBT people, but we did not think seriously about the cost of PrEP and how to address it. In some ways, we thought it was outside of our league. That's not what we do. I'm a nurse, got a psychologist, one's an epidemiologist, we know how to design these studies. But if we did not address costs, two things were happening. The study is expensive, and both the CDC and the National Institutes of Health, and at the time the White House, were saying we have to have some assurance that this is going to do something. This is a big investment.
Your point about investment, like, can you tie any money from PrEP given by taxpayer dollars or, given by federal government kind of loans to actually help with the research?
Maybe. It may not be from taxpayer pools. It may be from the private side. Okay. Yeah. Thank you for that question. So a quick lesson on PrEP and payment. So when we were doing this study, when this came up, who's gonna pay for this thing? We went around and did these listening tours. And one of the things that came up was insurance companies were saying, this stuff is expensive. The drug that works best for Black MSM at the time was this new injectable drug, because you didn't have to take it every day. So all these other issues that people came up with, that maybe you have unstable housing or whatever it might be, taking a pill every day was not working, by and large, for most Black men. Some, of course, but not in large, it was not happening. So this new drug that they came out with, they studied, they thought it was superior. Taking the injectable medication was superior in its efficacy than compared to taking the pill, mostly because it was less frequent dosing. But the injectable drug costs more, right? There's even another drug coming out called lenacapavir, which is supposed to be one dose every 6 months. That's probably not going to cost less than the pill. It's not going to cost more. So insurance companies are saying there are drugs that work, and there's some that you got to take every day, but they work. So, and it's cheaper. So we're going to pay for this. We can't pay for this $1,200 maybe more drug, and maybe the one that's going to cost $5,000. I'm making a number up. But they're saying we can't do it. But here's the trick. The drug companies are having lobbyists try to force the insurance companies' hand because they want you to take because they want to get paid. They want you to do well. They don't want you to get HIV, but they also want to get money. And the insurance companies are fighting and say this is too much. So the law passed that says you have to make PrEP available at no cost to people. Insurance companies have no choice, right? The choice they have is what prep they can offer at zero cost. It doesn't mean every prep, but there has to be a prep option offered at zero cost. They're going to pick the lowest cost option. I can guarantee that. And they can't deny you access to that medication if you're on their plan. So what do you think they were doing to avoid that, to get around it? Legal, but messy. What do you think it was? If you enroll in my plan and you want prep, I got to give it to you. And I got to give you an option that is, I got to give it to you. But I can choose what, I got to give it to you at no cost to you. And I get to pick what option that will be. Yes.
Would they look at pre-existing, like if you, or maybe they would say, oh, it's got a cost. If you had pre-existing, you're not exempt.
They can't do that.
Yeah.
No, so that's not one. What else?
This group covers certain medicine.
No, not quite. I thought you were going there. Not tiers. It's even more basic than all this. Anybody want to one more guess?
Did you
Are
buy
they-
pills at a time?
No, they just make sure you're not in my plan. Make sure that people who want to use PrEP are not enrolled in my plan. Once you're enrolled in my plan, then I'm stuck with the financial risk of having to pay for your PrEP drugs because you want PrEP. So they just make sure they don't go to South Atlanta and set up booths at the Martin Luther King Jr. parade. You're not going to find them there, right? Because you're going to mess around and come to my booth and look at my thing and you're going to sign up and now I'm stuck with having to pay for your medication. So it's not illegal. They're not obliged to enroll anybody in their plan. But once you're in it, then they have certain expectations. So we said there has to be, how I want to say this. The worst part of it was, getting ahead of myself. I'll come back to that. So we tried to figure this out. We said this can't work. We don't want to be in a war directly with the insurance companies and the drug companies. We have to figure out a way to move. We have to win without fighting. And I talked with, how many DMPs are in the room? Okay, DMPs are wonderful. So there was a DMP, named is Caroline Pacelli, who worked for PricewaterhouseCoopers, who has said, did you hear about this thing? She had not heard about it, but she had worked on Obama's ACA plan. She helped design some of the financial tools for that. I said, we got to figure out how to do this. It's legal, but it's wrong, and it's going against public health goals. So she said, well, what about risk adjustment? Who's heard of risk adjustment? ACA risk adjustment. What? Yes, all right. So most people have never heard about it. Even the people in DC who I went to talk to who work in insurance had not heard about this risk adjustment. So risk adjustment is this strategy where the federal government transfers funds from insurers who have higher risk enrollees, the ones who have lower risk enrollees, meaning financial risk. Insurers who take on people who are going to use the heck out of their benefits because they're sicker or because whatever. They're going to cost insurance companies a lot. Versus ones who people are relatively healthy, who are never going to hardly use anything, right? Their costs are going to be lower. Premiums can be nice, costs are going to be lower. And this one over here, who likes to take on everybody, is going to have a lot of expenses because all of these people are going to need a lot of health care. The problem with risk adjustment, I think I'll skip through some of this stuff, is it is designed for diagnoses. So in this world, if you have HIV and you have patients in your plan or enrollees in your plan with HIV, you can have your risk adjusted for that. Folks with HIV will cost more in general than folks without HIV. Everybody can accept that. Like, okay. But there is no risk adjustment for PrEP because PrEP is a preventive service. So what this says is that they assume that everybody who doesn't have a diagnosis has preventive needs, and that financial risk is spread evenly across all insurers, right? That makes sense if all insurers were all trying to get people in their programs on PrEP, but they're not. They don't want the risk, and they want somebody else to do it. But nobody wants to do it because they can't get the risk adjustment. And I know Jacob is going to take 50% of these folks, and Lisa's going to take the other 40%, and I'm just going to keep 10. But so there are three of us. So you take 50, you take 40, I take 10, and the federal government gives all of us 30. But he just spent 50, she took 40, and I only took 10, but I get a surplus of 20, and they're losing. So they don't want to lose. So they just say, we'll just stay out of this game. So what we had to do was think about how do we make this better? How do we solve this problem? How do we think about not just efficacy, does the drug work? Or will our strategy help make sure we can get people to use this, but can they actually use it? So I want to skip ahead. So Caroline, myself, and Gerard Retavosian went around and said, we got to figure out how to do this. We're doing a study, and as part of our study is figuring out how to make clear this lane, right? We have this strategy that we think will work, but it will not work in real life if people cannot get access to this, and cost is a barrier. The insurance companies are not going to pay more than they have to pay. The drug companies are not going to lower their price. We had to figure out something else here to make everybody win, right? It was not hard convincing very smart people in the federal government, or very principled about if we do this. One question was, what if we do this for PrEP? What about another preventive service for cancer? One of the things. Or what about something for heart disease? Like, do we have to include everything for every disease? So we tried to make cases you didn't have to do that. The point was, these were nurses, right, thinking about, we'll do this in America, but what about the rest of the world? We got to figure out a solution here. We got to just offer them evidence without offering a serious pathway to value or impacting their lives. And so this came out, this is in Health Affairs. They used my language, but it didn't say my name. So what they did is they proposed to include PrEP as a risk score in their 2026 benefit year, which will come out at the end of this year. They said HHS expresses concern that this prevents risk adjustment program from offsetting costs borne by issuers that attract more PrEP users and could cause issuers to limit access to PrEP. So folks said, why are you doing this? NIAID said, so why are you in DC? And are you enrolling? And what does this have to do with the study? And we said, it's because we have to have a new proposition. This is the issue, right? And so knowing that this exists won't do anything for these people if this is in the way. And so our research can't just be finding new ways and new drugs. It has to be finding new pathways, converting evidence into value and impact. And that's what we tried to do. Because if we didn't do this, we thought we could find the answer to this question. Sorry. We could find the answer to this question. We could know. Okay. We could know whether or not this works, right? And still do nothing about this. And that's where I think we were. And I think we have to get beyond that. It will not be easy, but I think it will be the new way. If we don't figure out how to do it, other folks will figure out how to do this. The last thing I will mention is something we're currently trying. This is a project in Ghana. In the US, we developed a study, an intervention called C4. We did it in DC, LA, and Raleigh, North Carolina. This is the model. It's basically a care coordination model that's based on self-determination theory. The idea is that people who have complex needs need very specific types of coordination. And if you do that, you can increase their PrEP uptake and increase their retention. They can stay in your program if you address these complicated needs that they have. We published on it. We knew how much it cost. We knew what activities were involved. We knew the role that goal setting played in that. And if you set goals and use care coordination, you would have optimal level of PrEP adherence. And that we knew the mechanisms of how it worked. We even figured out ways to digitize it. This is actually labor intensive, and we need to find easier ways to do it. The world was sort of going online at that point. We even put it online, and we said, we want to do an implementation study in Ghana. Yeah, we're going to take this new technology and take it to Ghana. A lot of patients, a lot of complex needs who need access to PrEP. And what do you think a major issue was for us in trying to do this in Ghana? What do you think came up? Electricity. I like that. No, not electricity. Cost. Did you say access and cost? Yeah. Right. No money. So the question was the same question. What if this works? What do we do with it? We can't afford it. We can't rely on our government to support it, right? Tax money, not electricity, but they can barely afford in some ways to keep the country running with electricity. How are we going to do this? Why would you come to us to do a study to generate evidence that sits on the shelf, essentially, for somebody to figure out how to use one day? We don't want to give you our time now for something that might benefit somebody else one day. That used to be what we say to people. Participating in this study might have future benefits for someone. Right? Yeah. They said, no, we're not doing that. That's over. So we had to move from efficacy to economy, the same sort of theme of this talk. So I'm going to just say a little bit about this guy. This is Shadrach Osei from Palm. He's from a small village in Ghana, Turquoise Breman. It's very difficult to get to, like incredibly difficult to get to atop this hill. And that's where cocoa farmers live. Cocoa farmers are all over. He's from a cocoa farming village. So this is Shadrach. Shadrach is now Dr. Shadrach. He has a PhD from Oxford and is now back at Yale Medical School studying to be a physician. I don't know why he's doing that. That's what he's doing right now. So Shadrach had an idea, which was he came from a very poor community who farmed and didn't have access to healthcare or education, especially the girls. And so they said, we got to find a different way to do this. Can we find ways to create value? So a small portion of people in Ghana are cocoa farmers, but cocoa is one of the largest exports from Ghana. That's what they're selling. Cocoa farmers make very little money per day, and most of the money they spend is on food, half of it, which means they have little to spend on education and on healthcare because they're trying to eat. So he said, there has to be a different way to do this. Can we figure out what are our assets and can we create value in doing that? So the way they did it was they created community farms. How can I describe this quickly? The community farm is everybody in this community knows how to farm. That's what they do. So they contribute some hours a week to this farm. And the proceeds that they generate from the farm, they sell that to, I don't know, Nestle or Lit or Starbucks. They sell that stuff. And then the proceeds from that fund their clinic. Fund the clinic and they fund the school for girls. This is their insurance program. So if you work on the farm, right, you get your insurance card. So as long as you put in your hours on the farm, you have your card, you go get your health care for free. But it's not free because you paid for it because you contributed to this business that they've done. So the proceeds from that make sure that you can have access to it. They have a physician, they have a nurse, they have a pharmacist. So again, the profits from this supports quality healthcare services in that rural area. This is actually pictures of that. This is the pharmacy, and this is in that clinic. So they've been doing this for 5 years, maybe more. So we thought we have to learn from them. One, they want an African way of doing it. I don't know if we figured out what the African way is yet, but they want to learn from an African model, not just what they do at Emory or Yale, can we do it here? They want to know what succeeded in Ghana. And so that's what we talked about. I just came back from Ghana a few weeks ago, a month ago, discussing this, which is not just can we implement this care coordination program, but how can you do it in a way that creates value? What's the market for it? How do you make it into a business that is sustainable? Because you cannot wait on USAID to give you money because it's not coming. That was the traditional way of doing it. We have a new intervention, we've tested it, we know we can do it, and we apply it for World Bank or Global Fund, USAID money. That's over. What do they do? So what are we going to do? We don't know yet. So we're thinking about how do we make value in the Ghana marketplace. One thing that came up is everybody needs this. This is incredible. Things are complicated. Now we have to lay off people because of these funding cuts. We need an online module or online platform that allows us care coordination that's going to reduce the amount of human effort involved. So they think we have a market, but a market is not a need. Some of you know this. A market is not a need. A market is an unsatisfied demand. So the question is not, will this be useful? The question is, will people pay for it? Will people give you money to do it? I was talking with Jane Gatewood. She's the new vice provost of global engagement at Emory. She talked about creating people said, our students need English language tutorial, our international students, because it's difficult and they get behind in classes. So she developed this program, not here at University of Rochester, for English language, because there was a need. And she said, but nobody used it, right? Nobody was willing to pay for it, right? So the market was not whether or not there was a need for it. There was clearly a need, but there was not a demand, meaning people were not willing to trade in cash in exchange for this resource. So we had to figure out, is there a demand for this? Who is going to pay for this? It won't be the guys in Ghana. They don't have that kind of money. It could be healthcare facilities. It could be government. It could be drug companies, right? If doing this makes it easier for folks to stay on your medication, maybe they'll pay for it. So we're trying to figure this out. And then again, markets are not people who use it. Markets are people who are willing to pay for it. The reason I'm bringing this up is two things. One, this was based on what I learned from Shadrach, from doing cocoa farming. And anytime something is successful, you will have what's third in it, which is imitation, right? So you have to be ready for that. So in the global marketplace, folks are going to be innovating. They're going to be moving, trying to survive this earthquake and figuring out how to do things differently. You will probably do the same thing. And you got to do it and get out there fast, because once you're successful, they're coming. The followers are going to come. That's normal. It's not like, oh, this person is biting my style. That's what happens, right? Folks are going to figure out that you figured out something that's golden, and they want a piece of the pie. And they will get a piece of that pie. So other schools and researchers will want a piece of that. Whatever you come up with innovative, they're going to want some of that. It will motivate us and you to be innovative to avoid becoming obsolete. The folks who are chasing you are also trying to pass you, trying to figure out what's next to get ahead of you. And then you'll end up back in this game of position. You'll figure out the new secret sauce. You're going to really maximize whatever you get from NIH or whoever it might be, and you'll stay there for as long as you can. But you'll know that at any moment, what will happen? The earth could move. The ground could shift. Hopefully in those times, we'll be ready. Maybe Emory's ready now. We're not ready at Yale. And many places are not ready. My colleagues across the world are not ready for this. But we'll have to get ready. I think we can learn a lot from business who think not just about does the product work, but can people afford it, economy, and is it going to do anything for anybody, which is the impact. Okay, so final thoughts. So I envision, we'll see if this is true. I don't think that the monuments will go away. I think there's still a place for places like us where we are. I think the difference is that we'll have to retrofit our monuments to move differently in ways that we thought were never, ever going to be anything. I remember my first time I saw a University of Phoenix commercial. And did you laugh? Everybody's laughing. Yeah. Saw it? Right. Gotta be a joke, right? It was not a joke. They were coming, and we followed them because we realized that people were willing to pay for it. That offered value. Not that the quality was better, but that wasn't necessarily the point. Folks that had been coming to us were going there. We had to figure out a way to get into that pie. So that will happen. Things that we thought we would ever do that. You have online programs, right? Yeah, okay, of course. There'll be things that there's no way we ever do that because we're Emory. There's no way we would ever get into this thing because we're Yale. We would never do that. We are immovable, right? Yeah, that is we'll learn how to move, or we will suffer blows, and some of them might be catastrophic, and we can avoid that if we think about some of these things. So is it sustainable? I think this idea of not just being a supplier of evidence, but figuring out how to help people use that evidence, offering the world or the market a way to put it into practice. In a sort of goofy way, it's like, it's a terrible example. Like, my mom used to go to these Tupperware parties, But Tupperware parties were, because it wasn't just like a catalog of a bunch of things. Like they were showing you the value. You would have a real life party and you have this stuff and that's all this food. And it's like, don't worry, you can take this stuff to go. Like it was this perfect like idea of not just supplying evidence of these things that work, but showing people how to use it and giving them real use for it, what people wanted. Is that a goofy example?
No, it's a great example.
Yeah, it's basic, but I mean, this is not new necessarily. Okay, so supplying evidence, I put supplying in quotes, might not be enough to be competitive anymore. I could be wrong, but I think we should be thinking about whether or not there's a new model. We should at least be testing. So the goal is not to get out of game of position and start moving. I think you got to be ambidextrous. You got to devote some time to defending your position, your profitable programs, your anchors, defend those, but you got to be experimenting because something is coming. You don't know where, you don't know when or how fierce, but you can guarantee it's coming. So you got to be ready by doing that, doing both at the same time. And then think about what's the value that you can offer the world today, but I think more importantly, the world to come. That might be hard to envision the world to come, but there are some clues we have about that. Online, that's always already here. Artificial intelligence, like that's coming. It's kind of here now, but it's coming and it's coming fast. We don't have 20 years to figure it out. Like we might have a couple years or a couple months, moving quickly. So think about what are we great at? You already know this. But what should we be great at or what could we be great at? And that's what we have to lean on and get to. Because we can survive these things. There's some very old companies around because they're innovating. I'm trying to think of a good example, but I can't think of a good example. Company, okay, Pirelli. Have you heard of Pirelli? Or is it a tire company? Wow, that's good. So, I didn't tell you. Yeah. Okay. It's the pride of Italy. So I was there recently, and Pirelli did not always make tires. They're known for tires. In some ways, they're known for fashion. Do you know what company Pirelli is? Do you know what it's good at? What it's great at? It is a rubber company. They're great at making fine rubber-based products. They used to make footballs. They made tennis balls. They made all types of things. But then there were competitors who came and who could do it better and cheaper, and people were buying it softer, cheaper baseballs, football, whatever they were making, right? So they ended up making tires. They didn't start out at the tire company, but they figured out something's going to change. And we better figure out what do we do that's great and figure out what else we can offer when the competitors come and they overtake us. And we got to figure out how to stay alive. It's an example about tires, but it is an example about innovating and surviving without ever giving up its soul. When you talk to them today, they say we are a company that knows how to innovate on rubber. That's what they've always done, even though you would never have associated them with tennis balls or baseballs or inner tubes or sailing boats, all the things that they used to make, because they can't do that anymore. But at the core of them is a rubber innovation company. So I think you can remain in education, research, global health innovation space, even if how it looks from the outside of what you offer to the world changes. And so I encourage you to think not just about the efficacy of the work that we do, but what it means for whether people can afford it, the economy of it, and what difference it makes in their lives, both people here in Atlanta, whether you're from Atlanta or not, and people around the world. So thank you. And yes.
Dr. Brown, I was thinking the idea of like being in higher education for 7 years. I think many of the researchers and things that we do at Emory and many research institutions is not really public. But the average public don't know what researchers do. The average public don't know what one of our professors are working on that could help their family with diabetes. And I think a part of it could be we're not great marketers of, like you said, of how do we make this thing that we're doing applicable to the people who can use it and also affordable.
I think that's right. I think if you want a public, tell me your name. Benjamin. Thank you, Benjamin. I think right now we're in an age where the public is more engaged. I don't think they're more informed, but they're more engaged for sure. And if they don't understand what you do, they're gonna go down to the state house or the federal and say, "Why are we giving money to these people that are sitting in their cute little offices and doing nothing, just spending up my taxpayer money?" That's what they think. That we're sitting around eating chocolates and doing nothing with their taxpayer money because they don't know. But the thing is why this is so important, because if they think all they do is create studies that sit there, and what is that? I pay a lot of money in taxes. I hate paying taxes. And what did that do for me or my mother or my kids? Many times it's nothing right now. But I think that will be a problem. If they don't understand what we're doing, how it impacts them soon, not maybe one day ever, but soon, I think the marker for that is going to be, uh, it won't be one. I think it'll be much harder to convince whoever's going to control this money to give it to us if we can't show how we're going to make a difference. I think the focus on money, how it's spent, is more acute than I've ever seen it. I'm a nurse. I didn't sound like it just now, but I've never talked about money. Like never. Like in my entire nursing career up until maybe 3 years ago, we didn't think about that. That was somebody else's decision. We created things. And now we got to think about, is it going to make a difference or not? We'll hope that it will. 15 years, 10 years, but now we can't rely on that. We got to have a role in making sure we get our hands dirty to figure out how to make a difference. Is there a question on
No, I don't see one yet.
Okay.
I have a question just to piggyback on what Benjamin just said. And, everything you just said is absolutely right. I mean, your talk did not disappoint. I love the powerful metaphor of movements and monuments. But my question is about, us in the scientific community in particular, and with the focus on education. We're very good about talking within our silos, like talking to each other within our disciplinary silos, but we don't do as good of a job as we can to make storytelling and talk to broader audiences, part of our education or part of our research mission. How do we do that? Because at a moment like this, I think it's sort of driven home the fact that we really need to do a better job of that.
It's a very serious question. I don't know. I think we have to have maybe there's forms. I think we have to have those stories, but they can't be theoretical. Right. I think we have to be able to say, here's what I did and how it impacts you, whether you realize it or not. I think that resonates with people. Like I know there's people who do work on dementia, who do work in cardiovascular disease, fibromyalgia. Like folks need to know this is what. Remember your daughter who got this treatment for this? Like that's what we offer. I try to do it here, right? So when people talk about this new access to PrEP, I have to tell people, nurses did that. It was me and Caroline. I say she was a DNP because they don't get all credit all the time, who helped figure out how we were going to do this, right? Nobody had ever figured out how to do this. And so folks will say, what are you doing in DC? What are you up there doing? Just sitting around, drinking lemon drops and yeah. But we're also trying to get some stuff done. But the key was to let folks know we did this, right? The investment that you made in us allowed us to make this happen for you. And I think we have to do more of it. Because if people they have to see what is in it for them. I can't say I blame them. But I think finding ways to get in front of people, exactly, even outside of this building, right? To get in front of folks who are not always going to be a friendly crowd, right? They don't have to be friendly. You got to be real with them about what you're offering. And if you're not offering, they'll smell it a mile away. But we do offer something. I think to the degree that we can point to things that we've done that has made this world better, we should just find ways to broadcast that as much as possible. So it might be a podcast. Y'all do a podcast, Emory podcast. Yeah, maybe, sort of. I don't know, I'm looking at you to do the podcast. There could be there are other ways that we could experiment with. We don't do them at Yale, but somebody brought it up the other day, and I was like, a podcast. Like, where are we? But I thought that's where the world is. Why not? I'm thinking, no, we'll publish it will put a link to the article online, they were like, no one's gonna look at that. So I think there are other ways we gotta experiment with how to get the message out, because people, that was my point about people being engaged and not informed. People will not turn on cable news, but will tune into a podcast and will treat that as authority. And so, if we're getting our messages out through publications and interviews on CNN, the right people who need to hear that are never going to hear that. We're watching that stuff. They're not watching it. So it's a very important question, but I think doing that will help us get a long way in the science.
Thank you.
Let me go over here and then I'll come to you. Yes.
Yeah, my question is basically, all of my, I'm Lisa Thompson, all of my research has been global health, 20 years, only global health. I don't have a domestic research portfolio. So I'm sitting on just a huge pile of dread that I will lose my funding. And my question is, one of my conservative relatives for the past 20 years has said, why are my tax dollars funding your environmental health research, which looks at a pollution problem over there? And we've always had to justify, well, this is a big problem there. And if we can learn from that big problem there, we can, extrapolate back to that pollution problem in the United States. Air pollution there is worse, and here, okay, we can find an effect on cardiovascular disease or pulmonary disease, by looking at a curve, exposure response curve. But I'm just wondering now, are we just completely sunk because, this administration is very transactional and probably is not going to really do much for anybody in a global health research portfolio that it's not bringing it back to us in a very direct manner. I think earlier we were doing a lot of HIV and infectious disease research because that was, we were seeing what could, infectious disease is something that would come back to our borders and therefore we would fund it. But I sit in study sections just last year that was looking at non-communicable diseases and injury prevention and LMICs that had no direct impact on U.S. I think all of those types of studies are probably just non-existent.
I think you're right.
I just was wondering what you think about where it's going to go with global health at NIH in terms of what they might fund.
I don't know if NIH will be the answer anymore. I would see that our financing, which I don't know how that would work, but will probably come from either philanthropic organizations, private industries, or local, country organizations. So there's this concept called social impact bonds. Remember that? So it's this idea that, let's say, scientists can come up with an idea, a solution, and investors will invest in that solution. And the degree to which, say, government, say, Kenya says, I want you to come solve my pollution problem. And you come up with an idea and you test it, and if it works, then they adopt it into every degree of asthma incidence that they decrease. The government, instead of spending money treating that, they give that money back to the investors. They go back to that. I mean, that's the interesting financial model, but I think it'll be something like that. We haven't figured out what that will look like, but I will tell you the capitalists are paying attention, because if you can appreciate that the U.S. government basically was sort of the engine of research and development, they've given that up. In some ways, they say we're not investing in that anymore. But the people out there in the money world, they know that we need research and we need discovery. And this institution has decided they're not going to do as much of that anymore. So the field is open. So there'll be money, trust me, because folks know we need to discover some things, and now they have a bigger claim on it. So Benjamin mentioned earlier about the investments in drugs. So some of the way pharmaceutical companies get away with it is because they get government money, and the government doesn't try to make a claim on your patent or your drug. We still need more drugs, but we won't have government funding. But there will be financiers who will say, I got billions of dollars, and I'll fund you to do it, but they will make a claim on that. They'll want to get something back. That's how the financing works. I think that's where we'll end up for a while, unless the old model comes back. There's plenty of money in the world. I think the people with the money will write the rules, and then we'll have to figure out are we going to play in that game, because the research can get done. The incentives will be different, and the expectation of what they get back from us who do it will be different than what they are now. Right now, they don't expect much from us but a paper and a report every year, and we're good. But the bankers are going to want more than that, and that just might be our reality. Sorry, I didn't have a.
No, I know, it's like changes day to day and hour to hour, but.
I mean, I want to talk with a finance person in New York because I want to start thinking about it now and say, what if this is what I was doing and I needed money, what would come to your mind about what would make you invest in this? And he's going to say, he's not a scientist, he's not a nurse, but he's going to say, I want to know this and I would want this. And so I want to know that now, right? So I can talk to folks about how we align ourselves, because there are a lot of people like him who are going to see this as an opportunity that they can exploit. And we should not be exploited, but we should leverage that opportunity, which will come with that money. But we can't be blind to it. So we got to be in different relationships with these people who, just like we know NIH, we're going to have to know the finance community, because that's going to be where the money is going to come from. But we just have to not be played completely in the process.
And here's going to be interesting, because I got funded from Grand Challenges Canada. And that was a 2-page proposal, so nice. But it went to the Guatemala, the Guatemalan institution received the money and I was a subcontract. So this is going to change the university. It's going to put it on the head.
Yeah.
Because a lot of these philanthropic organizations say, no, we're funding this institution in Ghana.
Yeah.
It's going, all the money's going there.
Yeah.
So
We've had that happen too.
You're going to be like, why did you do that? We don't get anything out of this.
Let me say one more thing, and I didn't forget your hand. The one advantage to the finance community is that because there's something in it for them, they'll be much more likely to take risk. So right now in NIH, you got to pretty much know the answer to your study before you get funded to do the study, because their risk tolerance is very, very low. And I think there'll be a 2-page proposal. You ever seen that in NIH? You know, like they want cut red tape. They want to get it out there. They want to see if it works. And if there's going to be a return, they want to get that return quickly. So I think there'll be more expectation, but I think there'll be lower barriers to it. And high risk studies will be more likely to get some investment, even if it's small. They'll get some to see, does this work? They'll want to figure it out fast. Let us know right away if it works or not, so they can just stop giving you money to do it. But right now, if you don't have a study fully fleshed out, you're never going to get NIH funding for it. I think that'll change. I think the finance world they tolerate risk more. They fund companies that they know, I'm going to fund 100 companies and 60 of them are going to fail. They accept that will happen. Because 40 will do extremely well, right? And they bank on that. And so some of us our studies might fail, but we'll get a chance to test. That's what science is, doing these experiments. So you got me going.
Screen time, most of life, it's like, I want to go play. It's like, all right, well, it's not in our house and it's time.
So just talking about, I mean, I feel I was at CGH this past weekend, and so there's a lot of communication about communication and the lack of communication to, our constituents as well as just the general public. I do most of my work in Uganda, and so what I've found, the national IRB now requires every study to get a community advisory. And so I'm just wondering if that gets implemented here, with our own institutional review boards, if that's something that might help improve the communication of what we do and, to the broader audience and our community members, so that when we do have things published that does affect them, that we have kind of that mandate to report back to them. And maybe that might be an avenue of try to, bridge this communication gap.
That's wonderful, especially if you let them speak, maybe not for the organization, but they can speak in ways that convey the message better than we can convey it. And I think I work with community advisory boards, they have more credibility. Like once people know, if I'm just sort of walking around with a t-shirt on and people ask me a question, I say, don't do that, man, or, take this or don't take it. People believe me, but as soon as I put on the lab coat, it's weird, right? I don't know if I can trust him, right? But if I had on my hoodie and my Timbs, they think I can listen to this guy. But I think it's because there's a sense that you are like me, and I can trust you because we got the same amount of things to lose. You don't have an interest in telling me something wrong. But once you know I'm a nurse or you're a professor, there is a suspicion. And so being able to have community, be able to understand the message of what we're doing and communicate that faithfully to the community, I think can help folks understand it. Because in some ways, once it comes from you as an institutional representative, you lose some of it. In the age of sort of anti-science, it wasn't always like that, but definitely now it is like that. In New York, during COVID, I would talk to the guys on the block. I lived in New York City for a while, and the doorman was the one who said, "This guy lives in my building. He's cool." That's how they got to it. Then it's like, "Oh, he works at Yale. He's a nurse. He's a scientist." So people had to know that I was cool and lived in this guy's building and I knew him before they could believe what I was going to say about school. I'm just a true story. But I think that's where we are. Yes.
Last one, and then I'll go online.
Okay.
That's right. And I also work on health policy here in the state statute. What I find, and I've been with legislators on the sides in a state that's polarizing like Georgia, is that they want to see tangibles. They want to see implementation. They don't often read the reports. They don't often read the papers, and inviting them on this podcast, partnering with them if you've got an area, if you're going to be working with their district, meet them for coffee, tell them, and then they also will, be more apt to bring you in for testimony and ask you, and then put maybe dollars in the budget. So a lot of times it's partnering and trying to understand where they're at too, because most people that are legislators in most states are not healthcare. Yeah. They're not science. They're bankers. They're just common everyday people, but they're also elected by the people. And so I think that's a good way to start, is by being available as well to talk to them. And sometimes it's also talking to the side you may not agree with. Yeah. And you might be surprised. Sometimes we'll sponsor your bill and move forward on things with you.
Thank you for that. That is absolutely, I agree with you 1000%. There's I wish I knew her website, but Tony Young is she's a leader in Washington, D.C. Got the name of the organization, but she does work in West Virginia. And what are you doing in West Virginia? And she does work on HIV and hepatitis B and hepatitis C. And so she started doing hepatitis work in Virginia for folks there's a lot of injection drug use happening there. And she said, she has a lot of money. And so I said, where'd you get this money? She said, I'm working in West Virginia. I said, West Virginia, what does that do anything? She said, you got to go talk to these people. I went and say, hey, listen, you got these people falling out in your parks and in the hospitals because now they have these diseases that they're not using clean needles or whatever. And we got something for that. And this is the evidence, this is what we can do. And so these are people who would oh God, this is being recorded, right? These are folks that they saw her, I think, in a dark alley one night, she might be in trouble, right? But she talked to them. She figured out what their interests were, yeah. And they figured out a way that she had something to offer. They had a need, and their funding. They had a congressional delegation go to West Virginia that she was leading, and I was like, I can't believe this. But I was saying, Tony, I don't know. She's like, I didn't do that. I went there and said, hey, listen, I see what y'all got going on here, and we got something to do for that, and it worked.
And they often have connections at DC, back to DC, the federal, and also with companies that they work with.
And they're not friends, they're not homeboys and homegirls, but they don't have to be. Like, they're working together to solve the problem.
I think it brings a good point to someone said online, private financing will also guide researchers towards streamlining costs for ROI and impact. There's room for reducing waste.
Yeah, that is true. Thank you.
Yes. On behalf of the Lillian Carter Center and the School of Nursing, Dr. Nelson, we want to thank you for your thought-provoking and inspiring presentation. And to all of you, thank you for your engagement, your commitment to improving global health and well-being. We look forward to seeing you all at our upcoming summer and fall lecture. Stay tuned for more details in the coming Until then, thank you again for being part of the special occasion for us, and have a wonderful afternoon. We thank you all.